Well, welcome everyone. It's really exciting to have this meeting in partnership with the African Society of Paediatric and Adolescent Endocrinology. My name's Tony Holland. My background is a psychiatrist, and until I retired, I worked at the University of Cambridge in the United Kingdom. But I've had a long-standing interest in Prader-Willi syndrome, and I'm presently president of the International Prader-Willi Syndrome Organization, which is why I've been asked to chair this webinar. But before we start the program, Suzanne Zapp, who's president of your association, is going to just say a few words by way of introduction. So Suzanne, can I hand over to you briefly, and then I can take it over again afterwards.
Thank you, Tony. Good afternoon, everybody. Thank you for the time that you are taking to participate in this webinar. And we want to thank, first of all, the International Prader-Willi Syndrome for this opportunity to have with us ASPAE Pediatric Association of African Society of Paediatric Endocrinologists, opportunity to share different information about this disease. So this is one of the first activity that we will have both, and we expect to have more. And please feel free to be active during this webinar if you have questions and so on. Prof. Holland will tell us how to proceed to ask our question. So thank you so much once more, and let us listen to what is prepared for us today.
Thank you, Suzanne. I'm going to share my screen. Again, thank you very much, everyone, for attending this webinar. We're really delighted to host this. But before we start with the program proper, I would just like to acknowledge the board of ASPAE for setting up this meeting, and particularly Suzanne, what you have done, and Paul Legong for his role in supporting Agnes in setting up this meeting. The format will be that I will be giving a brief introduction to Prader-Willi syndrome, and then the focus of the meeting is on endocrinological aspects of Prader-Willi syndrome, and Charlotte Hoiby from the Karolinska University Hospital will give a brief presentation. Then Engela Honey from the University of Pretoria will talk about experience in South Africa. I'd also want to acknowledge Agnes, that has worked very hard to set up this meeting. What we'd like is a discussion really to take place at the end of the presentations. And we think the best way to do this is if you like to put your comments in the chat box, and then Agnes, I think you're going to monitor the chat box, and then we'll forward the questions to me when we come to the question time. So I'm going to now just give a brief overview of Prader-Willi syndrome before we focus down on the endocrinological aspects. I think the point to emphasize is that Prader-Willi syndrome is a rare but genetically determined neurodevelopmental syndrome. So it's one of an increasing number of rare neurodevelopmental disorders such as Williams syndrome, Creutzfeldt syndrome, Fragile X syndrome. And although it's not rare, Down syndrome is another example of a neurodevelopmental syndrome of genetic origin. Prader-Willi syndrome is a lifelong condition that primarily affects brain development, but it results in endocrine dysfunction, which you'll hear a lot more about, intellectual and cognitive impairments, and a specific physical and behavioral phenotype, which again, I will say a little more about in a moment. The estimated birth incidence may be as low as about 1 in 30,000 or as high as about 1 in 16,000. But these studies have been done in countries such as the UK, Australia, and the United States. And we really don't know what the birth incidence or the population prevalence is in the majority or any of the countries of Africa. There's clearly an increased rate of morbidity and mortality, both in childhood and later life. So in early life, it's around the issues of failure to thrive that I'll come back to. And in later life, the morbidity and mortality may largely relate to the overeating and the resultant obesity. I think a point that we will want to emphasize throughout this webinar is that much can be done if you can make an early diagnosis and that you help the parents understand the nature of the syndrome. The point being is that whilst there are some treatments, you do not require great resources to improve the life of people with Prader-Willi syndrome. An early diagnosis and knowledge can make an enormous difference. Just to set the context, I've shown a picture here of Andreas Prader, who together with Labbert and Willi first described the syndrome in 1956. So what I want to do is to show how the phenotype of Prader-Willi syndrome develops over a period of time. So mothers who had previous children will often comment that in pregnancy they notice that the baby is moving less than they would anticipate. So there's often reported decreased fetal movements. There's either polyhydramnios or oligohydramnios noted during pregnancy, relatively large head to body size, and sometimes abnormal hand and foot position can be shown on ultrasound. And this is probably due to the hypertonia of the fetus. There are increased rates of assisted delivery and increased rates of both prematurity and post-maturity at birth, and birth weight is typically low or low normal. At birth, what is striking is hypertonia, so extreme floppiness, a poor suck, a weak cry, and males will invariably have undescended testes, and females a hyperplastic labia. And these early features, these features at birth, really should alert one to the possibility that this child may have Prader-Willi syndrome. And then in infancy, it becomes apparent that there are feeding difficulties, and often the child will require augmented feeding. This may be tube feeding. There will be poor weight gain, and there are other abnormalities noticed, such as hip dysplasia, squint, and early evidence of developmental delay. And then there's a shift in early childhood. As the child gets older, there's a gradual increase in appetite and weight. This has been described by colleagues in America, where often it's thought that weight begins to increase first, and then it's noticed that the child shifts from having difficulty feeding to excessive feeding, and you see the transition to hyperphagia or overeating. There are endocrine deficiencies of hypothalamic origin noted, so if the child will not be growing normally unless they're beginning to receive growth hormone, and there are also small hands and feet and facial dysmorphology. In later childhood, as the hyperphagia becomes apparent, there's a risk of obesity, and there may be concerns about sleep apnea, gastrointestinal problems may appear for the first time. There's evidence of developmental delay and intellectual disabilities. And you may begin to see some of the emotional and more psychiatric aspects of the syndrome, such as severe skin picking, repetitive behaviors, and the onset of emotional outbursts. In adolescence, dietary control becomes increasingly important because with increasing freedoms, people with Prader-Willi syndrome may seek out food, and as a result of this and as a result of excessive eating, may become severely obese to the extent that it can be life-threatening. There's delayed puberty, there may be the onset of scoliosis, again evidence of intellectual disability, particularly noted at school in terms of learning, evidence of social impairments, and some people with Prader-Willi syndrome may meet criteria for autism, and you may also begin to see the problems with mood instability and the emergence of affective disorders. In early adult life, there's the big issue of transition from education into adult life. And again, at this time, there's a risk of obesity because of increasing contact with food, availability of food, and the fact that supervision may not control access to food. There's a concern about physical health, largely because of obesity. There may be evidence, for example, of low bone mineral density because of the hormonal abnormalities, and mental ill health, particularly in the form of mental illness, such as psychosis, may become a problem. And there are ongoing, in adult life, there are ongoing both physical and mental health needs and the need for continuing support. here is just an example of the extreme scoliosis that may develop in adult life. And you can see the child here has had rods inserted in order to straighten the spine. So although the predominant problems here are endocrinological, and it's usually pediatric endocrinologists that take the lead in the medical care of children with Prader-Willi syndrome, the point about this slide is to say that there are serious medical issues such as scoliosis and such as psychiatric problems, which may mean that other disciplines are required in the support and care of children and then adults with Prader-Willi syndrome. The genetics of Prader-Willi syndrome are complex and are not completely worked out, although diagnostically we now have very accurate tests that will ensure that an accurate diagnosis is made. In summary, there are really two main forms of Prader-Willi syndrome. The most common form is where the person has a deletion on chromosome 15 of paternal origin. If you had a similar deletion on the chromosome 15 of maternal origin, you actually develop a different syndrome called Angelman syndrome. So the commonest cause of Prader-Willi syndrome is this deletion on chromosome 15 of paternal origin. The second commonest cause is what's called a maternal disomy of chromosome 15, where it so happens that both copies of chromosome 15 are inherited from the mother, and the copy of 15 from the father is lost. And a rare form of Prader-Willi syndrome is what's known as an imprinting center defect. Now, down below here, you can see a schema of the area of DNA, the deletion area of DNA, in which you've got certain genes that are imprinted. And these genes are quite normally switched off when they're inherited because they're imprinted when they're inherited from the mother. So if you lose the father's copy, either because of a deletion or because the father's chromosome is missing, then you develop Prader-Willi syndrome. And the gene that has perhaps got most attention is SNORD116. But I think the point to make here is that if you suspect the syndrome at birth, there are now reliable genetic tests that can be done that will confirm the syndrome. What is lacking is a full understanding about the link between the genetics and the phenotype of Prader-Willi syndrome. So the key issues, I think, that are really important is firstly, early detection and accurate diagnosis, because with genetic testing and an accurate diagnosis, you can help the family, the parents, anticipate this shift from the early failure to thrive to the onset of hyperphagia and help them manage and prevent the severe obesity that in the past was very common in children with Prader-Willi syndrome. The treatment is focused initially around managing the failure to thrive and ensuring an appropriate energy intake for the infant, and dietetic advice can be very important here. But then information for families and professionals, and this is where organizations such as yours and organizations such as IPWSO can be very important. Starting of growth hormone you'll hear more about from Charlotte, but then the importance really of ongoing support to families and monitoring of comorbidities throughout childhood and into adult life is really very important. Now, before handing over to Charlotte to focus on the endocrinological aspects, just to say a little bit about what the International Prader-Willi Syndrome Organization offers. So this is a global organization, and its international members are national Prader-Willi syndrome associations. We were founded in 1991. Essentially, we provide information and support both to national associations and also to families and professionals, particularly in countries where there are no national associations. We offer free genetic testing, which is undertaken at the Bird Institute in Italy, and really in partnership with national and regional groups, we organize webinars, workshops and conferences to really improve understanding about Prader-Willi syndrome in countries across the world. We also seek to promote research and to disseminate new knowledge as it arises about Prader-Willi syndrome. Now, that's a very quick and rushed account of Prader-Willi syndrome, but I hope that just gives you a brief insight to the syndrome. And then I'm going to now ask Charlotte if you would like to give your presentation on the endocrinological aspects of Prader-Willi syndrome. So over to you, Charlotte.
Thank you for the kind introduction. I'm going to talk about the role of the endocrinologist in supporting the care of people with Prader-Willi syndrome. And here are my disclosures. So I'll start to talk about growth hormone treatment. And I'll just let you know that Prader-Willi syndrome is an approved indication for growth hormone treatment in children with Prader-Willi syndrome in many countries. And it is also approved for treatment in the transition period and for adults in only a few countries. And in most countries, the diagnosis of adult growth hormone deficiency must be established according to guidelines for growth hormone deficiency in adults. It is well known that growth hormone improves head circumference, growth velocity, and final height in children with Prader-Willi syndrome. And it also improves body composition by increasing lean body mass and decreasing fat mass. But it does not improve or influence behavior. It has been shown that it has positive effects on cognition and motor development, but some of the studies were not significant. And you know, as Tony told you, about 70% of all children with Prader-Willi syndrome have scoliosis, but it has not been shown that growth hormone impairs this. Here you see two girls. One of them has been treated with growth hormone and the other not. And I think the difference is clear. In adults, there's only a few studies, but they have all shown a decrease in fat mass and an increase in lean body mass. And this is a CT of the abdomen from one of the participants in one of my old studies. And this is a baseline and after 1 year of growth hormone treatment. And you see the decrease in subcutaneous fat from 81.4 millimeters to 56.5 millimeters. And there was also a decrease in the visceral fat, the black parts in this, so it's less in the 1 year. And there are also some studies of physical performance during growth hormone treatment. They also showed improvement. There's only a limited number of studies concerning the effect on bone mineral density. They did not show any effect on bone mineral density. And for the neuropsychological function and quality of life, the studies also showed improvement. I think it's why I would like to just make it clear for you that growth hormone is not a weight-reducing medication. So it's only on body composition that it has effects. And the side effects to growth hormone treatment, the well-known one, it has not been shown to have any negative effect on respiratory parameters or scoliosis, and no serious safety concerns in the studies. There is a small increase in fasting glucose and also a trend toward a higher insulin and insulin resistance, but not a higher number of patients with diabetes. And this is what would be expected because of the physiological effect of growth hormone. And then there's mild ones with headache, nausea, and edema, and joint pain. They are only transient and dose dependent. And then I'll go on with central adrenal insufficiency. And in 2008, there was a study of children with Prader-Willi syndrome, and it showed that 60% had central adrenal insufficiency. The following studies could not confirm this high number, but central adrenal insufficiency is now not considered a a part of Prader-Willi syndrome. But of course, if the patients have symptoms, evaluation and treatment with hydrocortisone, exactly as we're doing in other patients, is of course indicated. And then the central hypothyroidism. There are also some studies here of both infants, children, and adults. And it seems like central hypothyroidism is less frequent in adults, but it's easy to check, and it should be followed or evaluated on a regular basis at any age. And then the hypogonadism.
You've gone very quiet, Charlotte.
I am maybe closer to the microphone. This is the most common hormonal deficiency, and it can be primary gonadal deficiency or hypothalamic dysfunction or a mixture between them. In the males, puberty is incomplete, and there is a lack of male body habitus, and no cases of paternity has been reported. In females, puberty is also incomplete. There's a primary amenorrhea or oligomenorrhea is very common. There's about 10 no cases of fertility worldwide. Sex hormones are used for induction of puberty in both genders. In adults, there's only one study of sex hormone treatment, and it was in adult males, and it confirmed the clinical experience that secondary sex characteristics respond well to treatment with sex steroids. And I think it should also be remembered that sex hormone treatment is not feasible for all. And many adolescents and adults have a desire for romance, fantasies of marriage, and a wish for children or family. And therefore, education in relationship and sexuality and contraception is needed. So in conclusion, Prader-Willi syndrome is associated with documented hormone deficiencies, and the role of the endocrinologist, whether it's a pediatric endocrinologist or an adult endocrinologist, is to diagnose, monitor, and treat hormone deficiencies. Hormone therapy does not change the intrinsic abnormalities of Prader-Willi syndrome, but it offers an opportunity to reduce some of the adverse consequences of Prader-Willi syndrome. And treatment of hormonal deficiencies can be a challenge due to somatic and behavioral phenotype. Thank you for your attention.
Thank you very much, Charlotte. So if we can now turn to Engela Honey, who's going to give a perspective from South Africa. And Engela works in the Department of Genetics and Pediatrics in Pretoria in South Africa.
Thank you, Tony, and thank you for the invitation. I am grateful that we do have such a large audience. I see some of my colleagues in South Africa is actually also present. I am just going to give you a brief overview of what is happening in Prader-Willi syndrome in Africa. I'm also asking Karen Clark. She's the chairperson of the Prader-Willi syndrome support group of South Africa. I'm going to ask her just to briefly at one stage talk about the support group. But let's just carry on and see if I can just get my slides. So genetic centers in South Africa is in most of the academic hospitals associated with universities. I am basically involved in the University of Pretoria, and I also do a clinic at the Sefako Magatu Health Science University. WITS, the University of Witwatersrand, has got a large human genetics department. We also have two universities in the Western Cape, the UCT, University of Cape Town, and University of Stellenbosch. There's one university in the Orange Free State who's got currently advertising posts in human genetics, and in KwaZulu-Natal we also have a pediatrician interest in genetics. I'm also a registered pediatrician, but has been working in genetics for the past 24 years. We do have division between the public sector and the private sector. The private sector is much larger and actually surfacing a smaller of our population, and they do offer services for children with Prader-Willi. There is a private endocrinologists, private geneticists, which also will offer services. We have both of the tests available at the University of the Witwatersrand. We do the methylation MLPA for the Angelman Prader-Willi syndrome region. And we also have the arrays, the chromosomal array, and in some centers, FISH still available for Prader-Willi, although FISH has been phased out. And the disadvantage of doing the array is that it only detects the deletion and not the uniparental disomy or the imprinting mutation. I had a quick look and see if there's any other support groups in Africa, and I know the International Prader-Willi Syndrome Association only report one group in Morocco, but I see in the chat that Egypt is starting up with a support group. A lot of the Prader-Willi support is also part of rare disease associations, and there's Ghana, Kenya, Tanzania has shown interest. The knowledge for Prader-Willi is, however, very limited, and there's not a lot of support, but I think we can. Well, nowadays that we have internet and a global village, we can actually basically have more connections between the centers. I'm currently seeing 3 families from other countries, one from the Congo who's actually staying in South Africa. There's actually a family in Botswana. I'm actually going to see them next week, and a family from Zimbabwe. So that's near to our borders. I have not had any contact with pediatricians from other countries, but I am available if they need me. Unfortunately, for people outside of our borders, we can't do much more than just counseling. But with the free testing available, I can guide the pediatricians to basically also, send tests abroad. So just actually, this is Karen. I don't know if Karen wants to introduce herself, because I think it is going to be important for the African societies to get to know her. So Karen, can you quickly introduce yourself?
Okay, hi everyone. I am Karen from the Prader-Willi support group in South Africa. Engla just wanted me to share what some of our experiences here in South Africa, how we support people. This is actually a slide presentation that I made for the IPWSO conference in Ireland. So I'll just go through quickly because I know we don't have a lot of time. How do I go to the next slide?
I will go.
Oh, okay, you can go to the next one. Okay, this is just showing where South Africa is. So, this is a picture of South Africa, over Ireland and England, where we were for the IPWSO conference, just to show how big South Africa is compared to European countries. And I know that other African countries are also as large, if not bigger, than South Africa. And so the point being that there's a lot of geographical distance between families, so it's not always that easy to get together. And so most of our support is actually done, via WhatsApp calls, email. So it's quite easy actually for us to incorporate other families with Prader-Willi elsewhere in Africa into our groups and to try and support them as well. So it'll be quite easy to, especially seen as there may be one here in this country and one in that country, and not enough people to start your own support group. So we're all very welcome to join us in South Africa. Okay, the next slide. Our support group in South Africa actually started in 1990, so even older than IPWSO. And since IPWSO started in 91, a delegate has been every year to the conferences. So we've been keeping up with all the latest research and knowledge on the condition. Okay, Ingela. Just go quickly. So yeah, so we do, where do adults live with Prader-Willi in South Africa? We're quite lucky. There are quite a lot of adult homes for adults with intellectual challenges and disabilities, where quite a few of our adults live as well. And parents have taken it upon themselves and often had the help of external experts to go in and train up the homes on Prader-Willi so that their children can live there, successfully with the food-related issues. And we do have the one home. This is a picture of the first home in South Africa that was started specifically for adults with Prader-Willi syndrome. The lady in the middle in the black and white shirt is the house mom, and the two on either side are the 4 adults living there. And then there are also quite a few adults that still live at home with families. They are for work. I would say most adults with Prader-Willi and other intellectual disabilities are actually working in sheltered workshops. Sometimes they just work at the home where they live, or otherwise they help out in a family business. As with the rest of Africa, there's a high number of unemployed people in the country. So, our adults with intellectual disabilities are competing for the same jobs as people without intellectual disabilities. So it is quite hard for them to find work. Okay, next slide. Okay, so in terms of schools, we're quite lucky as well. A lot of government schools have been set up for children with intellectual disabilities, LSEN schools. There's none really going to mainstream schools. Our mainstream schools are very big and the classes are very big, so it doesn't really work for them. Sometimes some of the mainstream schools will have a special ed class that they go to. And then we also have a school which seems to be quite unique to South Africa, which is a remedial school, which fits somewhere between the LSEN sort of special needs school and the mainstream school. So that can support them. And then a lot of people, and you'll probably find this elsewhere in Africa, are actually starting their own little home and cottage schools if they can't get into the government schools. Okay, I know that that's not really the issue. So in terms of clinics, as Ingela said, the government sector here probably sees about 80% of the population, and the private sector about 20% of the population. So what happens is that the government hospitals have actually got more sort of more specialists that and they see a lot, because they're seeing a higher volume of patients, they know the condition better, and they can refer people on to all the other therapists and things they need. And in the private sector, we don't have any specialist clinics, and the knowledge is actually quite limited, but they can also refer people on to the specialists that they need. And government services are free up until the age of 6. So this is just an anonymous picture of a waiting room in a hospital in South Africa, and I know that's pretty much the same across other African countries as well. It takes a long time to get a diagnosis. First of all, it's hard to recognize that they need the test. So that can take years. And then once they've decided they need the test, then it can take 3 to 6 months to get the appointment for the geneticist, and another 3 to 5 months to wait for the result. And then the specialist referrals will vary in length of time, depending on availability and what specialists they need to see. Okay, and then access to therapies and nutrition management. There is quite a lot of therapists in both private and government sector. So referrals will happen, but what happens is appointments tend to be infrequent, because in private sector, people have to pay for everything. Well, they have to pay for an expensive medical aid that pays for the therapies. And in the government sector, it's often oversubscribed, so they don't go that often to appointments. And then parents will be taught what to do with their child by the therapists to make up for the fact that you don't go that often. The dietitian will give you the meal plan, and then you have to get on with it. You can't keep going back all the time, because it just gets expensive, and all they're too booked up. Okay, and growth hormone therapy, I know the rest of Africa, it's probably even worse than South Africa. But yes, we do have it, but you have to pay for it. So there's very, very few people that actually can afford to use it.
Okay, Karen, can I quickly interrupt? Karen, I'm just going to interrupt quickly. I just want to say that it is very difficult to put patients on growth hormone. I have actually asked colleagues, even in the Western Cape, and not many children are on growth hormone, except if they can fund themselves. We also don't have the opportunity that all the medical aids will actually pay for the growth hormone. The problem is you have to be on the highest plan to have your medical insurance pay for it. So it actually becomes very expensive. So a lot of parents will opt not to give growth hormone, which I think is actually a little bit sad. But I have one patient in the public sector, one of the patients, the patient from Ghana, or the Congo, that is on growth hormone. They are funded by a special program. I'm not sure how our endocrinologists managed it. And at George Mukari Hospital, we have now a young adult, but I suspect that the growth hormone therapy has been stopped.
So, Angela, can we move on shortly, because we want to leave plenty of time for questions. So if you want to just...
We are about finish. So we're going to skip this, but I think this is just all our support systems. We do give money for children with disabilities. We also have a tax reduction. And then obviously we have support groups. We, as the Prader-Willi support group, actually falls now under the umbrella of Rare Disease South Africa. So there is some support in South Africa, and we have this wonderful support group. As I say, we actually also, and Karen can vouch for that, she mentioned that we have a Facebook forum, we have other pages, we have the WhatsApp group, we have email, the newsletters, and we all give one-to-one support and guidance. I think the major limitations is there's not enough trained health professionals, the diagnosis is still made late, access available, but the logistics of sending the sample, access to growth hormone is very limited in the public sector and very expensive in the private sector. The diagnosis is possible, but where to then? So I think we can get a group of interested individuals to have meetings, awareness, such as in this meeting. That's my, suggestion for the future. As I say, that is also what we envisage from the Prader-Willi syndrome support groups. There is limitations. We don't have a wonderful health sector in South Africa. We think it might be deteriorating. There is chances of a national health insurance, but I think that is far in the future. So we definitely want to improve our service, but it's challenging. This is just me and Karen's contact detail. And if you want to contact us, you're very welcome. I'm sure this will be available via the International Prader-Willi Syndrome Organization's website. Thank you very much.
Thank you very much, Karen and Angela. That was really helpful. So now's the opportunity for discussion and questions. I think the key point to make that has come out from the talks is that you as endocrinologists are going to be key to both the detection and support of people with Prader-Willi syndrome in your respective countries. And I think the point we'd like to emphasize is that much can be done, as I mentioned in my presentation, if you have knowledge about the syndrome. One of the key issues that we haven't really quite emphasized enough is this hyperphagia and the importance of managing access to food, what's often referred to as food security, in order to prevent obesity. And if you can prevent obesity, you can improve outcomes and life expectancy for people with Prader-Willi syndrome. So at this point, if we open it up for questions, we've got a few comments in the chat box, but if anyone actually has questions that they'd ask directly, please raise the hand and if I hopefully will notice it, or shout out if I don't notice you. But Charlotte, can I just start it off, because I mean concern has been expressed in the chat box that growth hormone may not be available. I just wonder if you could say a little bit about how you rate the importance of growth hormone and how perhaps endocrinologists in the African countries should be advocating for its availability in those countries. Or how important would you rate it?
It is important. It's an important metabolic hormone and also important for growth. But of course, if it's not available, then it is important that, as you said, to keep a diet, keep the weight, prevent obesity, and try to be physically active. That would help a lot. And I know it's expensive, so and it's difficult to.
Is there anyone that would like to pick up on this issue of growth hormone, discuss it further, or any other comments?
There were a few other comments in the chat relating to growth hormone. So someone was asking whether it helps with scoliosis and also whether it helps with the mental health of the person. And then there was also a question about when you would start on growth hormone and what tests you should do before starting the treatment.
In Europe and in many countries, it is what is it called? It's you can give it by the indication of Prader-Willi syndrome, so you don't need to do any testing in children, but it is not approved for treatment in adults or in the transition phase by the diagnosis of Prader-Willi syndrome. So in those ages, you have to test in those countries. And usually, I'm an adult endocrinologist, but the pediatricians start the treatment very early. So it's around at least 2 years of age. Some start earlier, but this is the age. And what was it? The scoliosis, I don't think it becomes better. Growth hormone mainly affect the muscle mass and the lean body mass, so it will not be directly on the scoliosis. And the fear has been before that this effect on muscle mass would make the muscles kind of draw the vertebra in a wrong direction, so the scoliosis would become worse, but this has not been shown. But I don't think it will become better by growth hormone treatment.
I think Malika had her hand up first.
Malika, yes.
Yes, my name is Malika. I'm a mother of a child with PWS. She just turned 3. And just want to comment about growth hormone. Here in America, we live in Texas. The age that they start here is as early as like few weeks. It's too early. Some endocrinologists, they require a sleep study for a child before they start growth hormone, just to make sure that they don't have any complications as far as like, you know, obstruction of like obstructive, what they call it, sleep, like if they have any issues with like the breathing while sleeping. But if they pass that test and then they just start the growth hormone. And my daughter started at the age of 9 months, and I've seen a tremendous change. She was very, very hypotonic. And I saw with the physical therapy and the OT and the speech and everything, that the growth hormone was really helping. It wasn't, you know, as like it helped her with strengthening her muscles, and you know, I could see like improvement. So I just want to comment on that.
Thank you, Malika. Just to follow up on this a bit, there is a question here about the growth hormone dosing. Is it milligrams per kilogram or milligrams per meter square?
It's milligrams per kilogram in children, and in adults it's by checking a marker of growth hormone called IGF-1. Right. So it's dosed according to age-matched control values. And in adults.
I think just to emphasize two things here in a way that IPSWO can help you. One is that IPSWO can help in terms of diagnosis and getting the genetic test. But with respect to growth hormone, I think what IPSO has done in some countries is provided the evidence that enables you in your country to make the case to your health authorities for the provision of growth hormone. So if any of you in your country feels IPSO can be helpful, we can help you assemble the evidence which you can then take to your health authority. So do contact us if you think that would be helpful to you. There's been quite a focus on growth hormone. Is there anything else on growth hormone? Do people want to ask any other specific questions? Agnes, have you picked up on anything that you?
We have Eckhard has his.
Eckhard, do you want to ask your question?
Yes, I don't have a question. Okay, I'm from Stellenbosch University. I just would like to confirm what Malika said. When I started off at Stellenbosch University, growth hormone was very expensive. In the meantime, the growth hormone price has come down significantly. There is, in other words, if you now look at the COVID pandemic that we had, we were using biologicals and the biologicals were far more expensive than growth hormone. This is a very good point, and one should actually mention this to your administrators. That has come down. The price halved over the last 5 years compared to what it was when I started. So that is one point. The second point is if you compare it to other expensive therapy, it is actually not so expensive anymore. So that is a very, very important issue. The other issue is you need to get the pharmacist on your side. When I started off at Stellenbosch University, the pharmacist blocked absolutely everything. She then retired and she was replaced by somebody else. And the new pharmacist was far more amenable. And initially we fought for growth hormone. We got the approval for growth hormone. In the end, nobody questioned me. And I just wrote up growth hormone for Prader-Willi. So if the parent and if the child is motivated, and they can prove to me that they can stick to a restricted diet, then they qualify for growth hormone and nobody questions me. So you need to have your pharmacist on your side, and then you are probably okay, because you can prove that the prices come down. There is ample of evidence that it works. And the other thing is I also have subjective evidence from my patients. Formerly, we didn't have it available in the public sector in South Africa, but now I have it available and we definitely see a difference. So the evidence is there, scientific evidence is there, the subjective evidence is there, and you heard it also from a mother that spoke before me. That's just what I wanted to say.
Oh, thank you. That's really helpful.
Suzanne, I can add also that now there's biosimilars, so they are less expensive to produce. So this also helps the prices.
Yeah. Suzanne, you have a question you wanted to ask or comment.
Yes, thank you. Three rapid comments. The first one is, from what I heard from your presentation, Tony, maybe we need to share this in other groups of pediatricians. I'm thinking about nurses in maternity and general pediatrician. Am I right?
I think that's
to
right.
Increase early diagnosis.
Yes.
Yeah.
Yes, I think that's absolutely right. Yeah.
Yeah. My second question is there any impact of growth hormone on mental health? And my last rapid question addressed to Karen, for adolescents and adults with Prader-Willi, really, I want to say it's a great job that they are doing there in South Africa. But I'd like to know in which kind of job or work are they doing as adults? Because I saw they try to do a lot to help them be insert in social activities. These are my 2 rapid comments and questions. Thank you.
Charlotte, do you want to just address the growth hormone and mental health? Then we'll come to Karen.
Yes, there are studies showing that the mental health or their the cognitive function gets better. There are, but the behavior is also affected positively, so the outbursts are less frequent. So it has effects.
Yeah.
It has.
Karen, do you want to? You've got both a question or a comment, and you might address Suzanne's question. You're muted.
Sorry, it was taking a while to unmute. Yes, for the adults, a lot of charities have actually started workshops for adults with intellectual challenges and disabilities. And so that's actually where most of them are going to work. So they're not actually getting paid as such. It's more like sheltered employment where they're almost volunteering. And I don't know if they're earning income. And then, like I said, some people are involved with family-run businesses. So they might be getting paid to do that, but it's also, you know, it's set up by family or family friends. So I don't know of any people who are actually got a job they're actually earning an income on. I don't know, there might be some, but I haven't heard of any. So to answer that question. And then I had a question actually for Eckhard. Thanks so much for joining the meeting, Eckhard. It's great to hear from you. I was just wondering, like, is it possible for endocrinologists in South Africa to consult with a patient somewhere in Africa if they want to start growth hormone and pay for it? Because as you say, I mean, the price has come down quite substantially. I mean, it is still expensive for a lot of people, but I don't know if that's possible, because I don't know if there's even laws of getting the growth hormone into some of the other African countries, and if that's the problem. Because we do have it available here, it's just that you have to pay for it. So I don't know if they can get it into Botswana or Zimbabwe or wherever, where there's maybe not an endocrinologist. Would they be able to do a virtual session with an endocrinologist, you know, like you, Eckhard?
Eckhard, if you want to answer that briefly, we're running out of time, and there are a couple of other questions I want to address.
Do I understand you correctly? You are suggesting that we do a virtual consultation with someone in Botswana. Is that what you're suggesting?
Yes, or via their pediatrician, if there isn't an endocrinologist there that they can see, and if they can access growth hormone therapy.
That would be possible, but I think you have to have direct contact with the patient. So if a pediatrician would definitely be needed, you know, I don't think one can actually develop a good rapport with the patient if it is virtual, if you've never seen the patient, you know, before. I don't think that's that. I mean, the people who treated COVID patients claim that they can do it, and we could certainly do it in diabetics, but I'm not so sure a Prader-Willi syndrome patient is a bit different than a simple diabetic.
Okay, thank you. Can I just, there are a couple of other things in the chat here. Can recombinant leptin help in this condition? I think the answer to that is clearly no, it can't. But there's also a question here about the management of type 2 diabetes in Prader-Willi syndrome in terms of medication. Charlotte, do you want to say anything about?
Yes, if they get diabetes, then they are treated in the same way as everybody else with diabetes. So no difference.
But the aim, I think, would be to try and prevent it through
of course.
prevention of.
Yeah, but if they get it, I mean.
Yeah,
yes.
yeah. Now we are getting close to the end of the meeting, but are there any particular points that haven't been discussed so far that any of you would like to raise? Do raise your hand. I can't see anything. Agnes, is there anything you can, anyone? No. Or any other points you see in? I think what I'd just like to emphasize as we bring this meeting to a close is that you as endocrinologists are going to be central to the support of people with Prader-Willi syndrome in your country. And it's wonderful that you have been part of this webinar, and I hope that you will continue to link in with the International Prader-Willi Syndrome Organization. We have in the past run a series of what we call echo sessions. This is an online series of webinars and mentoring sessions about how you best support people with Prader-Willi syndrome. And I'd encourage you to keep an eye on our website, because we will almost certainly be restarting those in the near future. We've had a big focus on growth hormone, which clearly is important. And again, if you feel IPSWO can help you in advocating in your country for the use of growth hormone, we'd be very pleased to do that. And please contact us. But of course, the treatment and support of people with Prader-Willi syndrome goes beyond growth hormone. And you as endocrinologists will be asked about diet. You'll be asked about food security and preventing obesity. You'll be asked about the management of diabetes, the treatment of sex hormone deficiencies. And almost certainly you will also be asked about how you help some of the behavioral problems. Because the reality is, in almost all countries, there aren't the specialists or people interested in Prader-Willi syndrome that you would like. So do help become familiar with all these different aspects, as well as the endocrinological aspects, because you're bound to be asked about them. Would you agree with that, Charlotte? I mean, you get asked, I'm sure, about many different things over and above endocrinology.
About anything in relation to the syndrome. So there's a lot of questions. As I said, I'm an adult endocrinologist, and there's a lot of questions about mental health, behavior. Becomes a very big problem sometimes when they get older.
And Suzanne, is there anything you would like to say as we bring this meeting to a close?
Just to say again, thanks very much to IPSWO for this webinar. As you can see, an hour is just enough. It's not enough. I think we need more. I think we need more, and I expect that we'll have other meetings, maybe face-to-face and during our different congresses. Thank you, and thank you once more.
It's been a real pleasure. I would just like to mention that on this call we have Francois Besnier, who's Vice President of IPSWO, and who his name suggests is from France. And I think, Francois, you are really leading on links to French-speaking Africa, if you like. So we appreciate that language can be an issue. So we do have Francois who's helping with that. So he's just waved to everyone just now. So can I thank everyone for joining and giving up your time. It's very much appreciated. I hope very much that we'll meet some of you face to face in the not too distant future, and we'll obviously remain linking with your organization. We very much value that link. Agnes, is there anything you'd like to say before we finally close the meeting?
We're going to sort of tidy up this webinar, and then we'll try and put it onto our website. So if anyone did miss the beginning, we will be putting it up on the website. And just a big thank you to Suzanne and the board of ASPAE, and we really hope to be involved in your conference coming up in Cameroon early next year as well. That would be brilliant.
Good. Well, thank you very much, everyone, and good night, and see you at some point in the future, I'm sure. Goodbye.